Hello, everybody. Thank you so much for joining us this afternoon, this evening, and this morning, depending on where you are. We are Fair in Medicine, the Foundation for All, or Fair for All, is continuing our gender series, and particular, the aftermath of the CASS review. And today's title, we're focusing on the state of gender reform in the United States, the UK, Australia, and beyond. We have a fantastic panel of panelists that are international, and our moderator is going to be FAIR's own advisor and writer, Lisa Selin Davis. So Lisa, I'm going to hand off to you.
All right. Thank you, Nikki. And thank you, Bernard, Jamie, and Anna for doing this with me. And let's just start by each of you just doing a 1 or 2 sentence intro. So Anna, let's start with you, and then we'll do Bernard and then Jamie, alphabetical order.
Okay, hi, I'm Anna Hutchinson. I'm a clinical psychologist based in the UK, been working with gender distressed youth for over a decade now and spent some time in the Tavistock GIDS and have been speaking about the need for psychotherapy for these young people ever since. So it's nice to be here. Thank you for inviting me.
Thank you. And Bernard?
Hello, I'm Bernard Lane. I'm a journalist based in Sydney, Australia. And I've been writing about gender clinics since 2019, initially for the National Daily newspaper here in Australia, but now on a Substack.
Gender Clinic News.
Yes, that's right.
Plug. Okay, thank you. And Jamie?
Hi, I'm Jamie Reed. I'm a whistleblower from a pediatric transgender center here in the United States. I'm currently joining you from my 14-year-old's bedroom because my home office is under construction. Sorry. Enjoy the Star Wars decor.
It's perfect. And I am in my late father-in-law's office with no idea, probably a tremendous amount of Cold War historical literature behind me. So we're going to talk about the CASS review and how it's landed in England and other parts of the UK and Europe and Australia, and how it maybe didn't land in America. And so maybe we'll also touch on some of the other crazy things that have been going on in America in the last couple of weeks. So if we could just, we're assuming a lot of these people know something about the CASS review, but Anna, if you could give us a brief overview of what you were blowing the whistle on and how it led to the CASS review and what the CASS review said, which I know is a lot to condense.
Quite a lot.
Yes, it's hundreds and hundreds of pages and you know, over
many years. But
Yeah.
you told me you've got a well-informed audience, but just to set the scene, in the UK, we until recently had one gender clinic for young people based at the Tavistock in London. And from about 2016, 2017 onwards, people were beginning to raise concerns about how that clinic was functioning. Gradually, some of those concerns came out of the clinic and into the media, and a variety of things happened, including a judicial review in the UK. And as a result, NHS decided they had to look at the evidence base for the treatment they were giving the kids. And they initially did 2 what we call NICE reviews. So in the UK, NICE means, in a medical sense, the National Institute for Clinical Excellence. And these are the people who look at the evidence, look at the costing, get stakeholder involvement, and make recommendations about what medication for what problem. And the NICE reviews came back saying that there wasn't enough evidence either way for the use of puberty blockers or cross-sex hormones for kids. And that was in 2020. And they'd employed somebody called Dr. Hilary Cass, who's an eminent pediatrician, to do the NICE reviews. And when that came back, she said, look, I think there's a lot more that we need to attend to here. She'd already heard things across the board that concerned her, right from when a young person first speaks to a GP to, you know, transitioning to adult services. So NHS England asked her to conduct an independent review across the board on how to support young people questioning their gender or identifying as trans. So that's how it all started. And she spent about 3.5 years doing that. And the CASS review comes from a very clear evidence-based medicine perspective. So she looked at evidence, data, qualitative information. She spoke to stakeholders, she spoke to young people, adults, charities, parents. And what else? Evidence-based medicine. So we've got values and preferences, we've got the evidence, and she spoke to professionals, of course. So she sought lots of professional opinion, and that included across the world. So looked at care pathways and guidelines across the world. And over those 3.5 years, there was an interim report, which she said, at which point she said, I don't think one service for these kids is safe. You know, we knew that the waiting lists were getting very, very high, thousands of young people on the waiting list, very toxic environment for everybody working in the field. And then the final review report came out in April, and it was 388 pages long. I'm sure you've all read every single page. And along with that came nine systematic reviews, which were conducted by the University of York, which is one of the centres that the NHS employs to do this. It really is the most broad review of pathways, demographic changes, treatment models, that I think is in existence in the world now. Does that give us a potted summary, or do you want me to go into content?
Yeah, it does. But of course, I have 18 questions I want to ask just about that. And I think we should talk a little bit about the recommendations and just say again that in evidence-based medicine, when the evidence is of generally low quality, you talk about, you also consider the values and preferences, as you said, of the patients and their families, and professional expertise, and there is no professional consensus. And then there's the question of informed consent around young people and their values and preferences. So
so there is, but then we are also talking about young people who, by the very nature of them being young, are vulnerable, and you always have to weigh up cost and benefit of any recommended pathway, don't you? So that's what the review does as well. So yeah.
Okay, and we're going to talk about the recent criticisms of the review later, but why don't you quickly tell us some of the general recommendations?
Okay, so there are 32, so I won't cover them all. In fact, I haven't memorized them, I'm sorry to say. So what I'll do is just talk through what comes to mind, and then other people can add in because there'll be things that I've missed.
Okay.
But essentially, from an evidence-based perspective, nothing had changed between 2020 and 2024. There still wasn't enough really good quality evidence to really answer any of the questions, both about medical pathways, but also about psychosocial or psychological interventions. So, you know, CASS talks about working in an area really where there's a profound lack of knowledge all round in terms of evidence, and traditional evidence base is lacking in this field, and she makes that very, very clear. In terms of recommendation, she recommended quite clearly, for example, around the puberty blockers, she recommended that we stopped offering those to young people because the only findings that were consistent about puberty blockers were that they do block puberty, they do impact bone strength whilst a young person's on them at least, and the vast majority of people who start puberty blockers proceed onto a cross-sex hormones pathway. So based on that, she said, we just don't know enough, we don't know. And I think what's really important was she pointed out that nobody really agreed about the purpose of the puberty blockers or even what outcome measures we should be using to evaluate them. So as a result, in the UK, nobody is currently prescribing puberty blockers to new patients coming forward. Those that are already on them are staying on them. So that was quite a profound impact of the review. But she talks about other things that I think are really important in this field as well, about sort of social transition. She talks about that not being a neutral act, and that there's so much unknown about the impact of a social transition. Again, however we measure that, because for one person it might be a name change, another it might be a whole identity change. let's think, what else? What are the other recommendations? She recommends, she says really that a medical pathway probably isn't going to help most of these young people. And therefore we need to be doing what we do in other pediatric and mental health services for kids, which is a very holistic assessment of all of these needs, because as we all know, and as the CASS review sort of reiterates, as a group of kids, they're really vulnerable. They have a lot of complexities. They look more like a complex mental health group than mainstream young people. And we can talk about why that is, but they certainly need a lot of help, not just in relation to their gender. And she really suggests sort of psychosocial, psychological approaches as the first line for helping these young people.
Yeah.
So Anna, I'll jump in for just a quick second
Yeah.
on the recommendations. So the first one is I'll shamelessly plug that on the LGBT Courage Coalition Substack, we're actually putting out one recommendation per day for the entire month of July with garden photos just to lighten the mood. But we did, there are 32 recommendations. We condensed them down to 31. One of them did seem like it could be really easily tied together. But I just had two questions to kind of compare the US to Britain and maybe even Australia in those recommendations. One of them is that basically we should be screening all of these kids for autism. Or at least any child that presents that have any autism kind of concerns. And my question really is that assessment accessible in your countries? And what is your kind of gold standard assessment? So here, I think that would probably be the ADOS.
Yeah,
and
ADOS and the ADI, same.
Okay, so the same kind of assessment, but here it can be challenging to get those. Are those?
Yeah. I mean, there's what somebody recommends from these reviews, and then there's what is done, and there's what can be done with the resources. And I've been doing a lot of training of staff in this field, and quite often what comes back is this is a great idea, but what these local services that are going to pick up much of this psychological and psychosocial work is are there going to be enough resources put to them? I know the intention is there, but it's going to take a while for this whole system to change. And you're absolutely right, waiting lists for assessments for ASD, for example, are long often already. So it will be putting pressure on a very tired, under-resourced system.
Yes, but in the US, one of the things I hope is that I had discussed in clinic that a number of these patients could have really benefited from the kind of wraparound care that we provide to children with autism diagnosis. And one of the concerns I continue to have is if we were referring a child from gender over to autism, that they would see the referral and kick it right back. So I'm hoping that part of what CASS review is going to do is really put it back on these primary services. You cannot see gender and just say tag not it and send it right back to the gender service.
There's a whole section that I didn't bore you with because it's very sort of local to the UK about how we're going to do this, but essentially it's going to be a much more tiered system with a group at the top who try and create consistency, consistent measures and values, for example, and assessment approaches, and then it should tier down into primary care, like so entry point care all the way down, and actually each child should have an individualized assessment, what we call an individualized formulation, and then a care plan that might take them anywhere really in the system, sort of up or down in terms of severity. Yeah, but we do come back to resources again, I think. I think one of the things that stood out to me, which I think is really positive, is that CASS recommends that every clinician who is also working in the gender service also works elsewhere in pediatrics or mental health, to sort of try and avoid that, what happened at the Tavistock, which was where it just became a group of what we call colloquially, don't we, sort of gender therapists, who perhaps didn't have that expertise, and certainly as time went on, maybe lost that expertise in more broad mental health, neurodiversity, and things like that.
And this is such an interesting issue of people, some of the reviews of some of the criticisms of the CASS review are, not all of these people are gender clinicians, but that is actually what that's what we need is someone from outside to look into it. But generally my impression from over here was a lot of people in England took the CASS review seriously. There were people who had not felt comfortable admitting that there was a problem, now able to say, yes, we need to do this differently. It's not the, let's ban it all kind of red state, blue state issue we have here, but there was an admission of a need for reform. Mm-hmm. So, Bernard, will you talk about how that was received in Australia? And you also attended, I think Hilary Cass actually presented right at this just recently to some Australian psychiatrists and clinicians, and you also cover not just Australia, but you're really looking internationally at gender clinics and the pediatric gender medicine. So can you talk to us about how it landed there and in some other countries, as opposed to at least the admission from resistant parts of England that things needed to change?
Okay. Well, in Australia, the response has been pretty muted. Our health ministers, we're in a federation, haven't said very much about it at all. The general line, these health ministers from the centre-left Labor Party, the general line, which is entirely consistent with the gender clinics, is that the UK and Australian health systems are very different. And so the suggestion is that the CASS review, therefore, is not relevant. Another line is that CASS is either irrelevant because of the different systems, or where CASS has good recommendations, the Australian clinics are already doing all of this. And so there's been really no acknowledgement by our medical authorities or at the political level that the evidence base for the very same treatments, the puberty blockers, the cross-sex hormones, the evidence base has been shown to be so weak and uncertain. There are some attempts to get up an inquiry in various states, but nothing serious has happened yet. New Zealand's interesting because they've had a change of government. They've gone from centre-left to centre-right, and they, like the NHS, quietly abandoned the claim that puberty blockers were safe and fully reversible, and they commissioned what they call an evidence brief, which is, well short of a systematic review, but that has been endlessly delayed. And the most recent delay has been partly because they say they need to consider the CASS review. I think that in Chile, the situation is very interesting because they went from, they had a government that was very committed to gender ideology, and I'm told that they had virtually no detailed skeptical coverage of gender medicine at all. And then in one particular publication, which has a big reach, a journalist published a massive piece which covered so many aspects of the issues, including CASS. And within a matter of days, a major Catholic health provider, which had been providing pediatric transition, decided to pause it, and the national health authorities also suggested a pause, and they appointed an expert panel. And there's some uncertainty about whether that panel is going to be independent or a sort of a gender affirming stitch up. Where else has CASS? There was sort of skeptical movement in Germany and Italy before CASS, so I'm assuming that CASS will push that along. I think that's just a general overview. In relation to the webinar, this was hosted by our smaller psychiatric organisation, not the main college, but it's called the National Association of Practicing Psychiatrists. And they had adopted a cautious, psychological methods first approach to gender dysphoria a few years ago. And I think through some personal connections, they managed to get Hilary Cass to agree to present. She really just gave an overview of the review, and she was asked quite directly whether or not she saw it as relevant to Australia. but she was reluctant to offer that opinion, given her distance from it. But I suppose one other point I should mention is that in Australia, apart from my old newspaper, The Australian, there was not really much coverage at all. We have a public broadcaster, the ABC, which has some of the problems of the BBC, but without the virtues of their, was it Newsnight, Anna, the BBC Newsnight program? So we have a counterpart investigations program on the ABC, the public broadcaster in Australia, but it in effect has been running interference for the gender affirming model. I think there's only been maybe one newspaper, The Australian, that's reported the fact that in those reviews commissioned by Hilary CASS and run by the University of York people, the main gender affirming guideline that is used in Australia was evaluated and found to be very poor. And we know that our Federal Health Minister has been briefed on that by his health officials, but he hasn't said anything about that publicly, and neither have the state health ministers who have primary responsibility for the large gender clinics in our public children's hospitals.
Yeah, I noticed that that CASS also basically she concluded there were only two proper sets of guidelines, right, which were Finland and Sweden, and
Yes.
and everything else was not evidence-based. And we should come back to this, because in a little bit we're going to talk about this Yale critique of CASS that came out, and they keep saying a little bit, let's see, I could summarize it as evidence schmevidence. It's a little bit there. They're saying you're putting too much weight on evidence. So we'll get into that. But it did seem like there were, in Germany had released some kind of statement about we're also going to reevaluate and pause. And there were a few other countries that did that. And it doesn't mean that it's going to happen, right? They announced their intention, but it seemed like for many countries, it was some kind of off-ramp. And I think in America, because we're so polarized and we're fighting this as a political battle and in no way as a scientific battle, this also seemed like the first real possibility for the Democrats, who are the ones kind of upholding the gender affirming model, to have an off-ramp. And Jamie, why don't you talk about what happened or didn't happen here and how it's played out? Because let's start there.
Yeah, so I think in the US, those who were in the know knew, and they were greeted the news with a very open mind and really wanted to read about the recommendations, and saw that there would be a number of similarities from those recommendations from what CASS was, suggesting for the United States. But those who had never heard of even the CASS interim report probably still today know nothing of this final report. And I think that there are still probably large numbers of parents who have children with gender distress that have never heard of this report. I think there's still parents who have children with gender distress who've never heard of WPATH. So part of what we really have to address here in the US is a real lack of media coverage and an uneducated public on the key players and the true, I think we could call it, scandal that's emerging out of the US, especially around WPATH, and how that has really been playing out with our high-level politicians. I mean, and in some level, what I'm really interested to know is, like, Bernard and Anna, is WPATH have much of a stranglehold in your countries as it does here? I don't see it
And let's just say for the 7 people who don't know that WPATH is the World Professional Association for Transgender Health, which is a group made up partly of clinicians and partly of activists, and also includes lawyers and electrologists and all kinds of people with any kind of stake in gender medicine. And they publish what they call standards of care, even though they're an advocacy group and not a medical group. And in theory, that's what America sort of follows. And there are lots of issues with that, which we won't get too far into. But certainly in America, we fall back on that. And they have had, they've had a strong influence on gender medicine around the world. So yeah, and I think when Finland and Sweden wrote their own guidelines, that was seen as breaking from WPATH, and the CASS review is also seen over here by those of us in the rabbit hole as breaking with WPATH. So now that I've said that, yes, Anna and Bernard, anything you want to say about?
Yes, well, in Australia, it seems to me that the WPATH influence has been greater than perhaps in the UK. We have a local franchise, the Australian Association, Professional Association for Trans Health, AusPath, and it has endorsed the gender affirming guidelines that were issued by a children's hospital, the Royal Children's Hospital in Melbourne. And those guidelines, when they were released in 2018, were promoted as more progressive than WPATHs, more progressive than the endocrine societies, in the sense that they removed all minimum ages. In that sense, I think, from the point of view of the gender clinics and their health ministers, on those rare occasions when they've been asked questions about the safety and the efficacy of care in the children's hospital gender clinics, they typically have cited those 3 guidelines: the so-called Australian Standards of Care, endorsed by AusPath, the WPATH guideline, and the Endocrine Society guideline. So those sort of WPATH, the Endocrine Society guidelines are quite influential. I think it's a rather similar situation in New Zealand. There's a local franchise of WPATH. They have their own guideline, which, like our Australian guideline, was rated very poorly in the guideline evaluation by the University of York.
So it would be potentially safe to say then, okay, so let me just take this one step back. So CASS is basically saying the only 2 guidelines that really can hold weight and really be utilized as guideline is Finnish is 2020 and Sweden is 2022. But Sweden is really, really heavily going back to the original Dutch model. And it's really basically saying under research, study, or strict criteria only. So if we think about these 3 models of care, what CASS is kind of saying is that there's the Canadian model, the Netherlands model, and the American. And it's kind of saying the only guideline that holds up is potentially the original Dutch. And what I'm hearing from you, Bernard, is potentially that Australia, New Zealand is already knee deep in the American model, and the American model being that WPATH kind of child at any age knows their authentic identity and will benefit from transition at any age.
Yes, I think Australia and probably New Zealand closer to the American model, although there's a history of connections between the Tavistock GIDS clinic and our leading gender affirming clinic at the Royal Children's Hospital, Melbourne.
But I don't want you to think that WPATH doesn't hold power in the UK, because it still does. I mean, it was absolutely guiding the work of GIDS. And there are, of course, many affirmative clinicians who will still quote them readily. And, you see this sort of circular thing, don't you? CASS says there's no evidence for the WPATH guidelines, and then people quote WPATH to undermine CASS. But I think again, we're lucky with our press and the freedom in the press, really, and the fact that the concerns started that bit earlier, because I just did a quick Google, because I seem to remember, and I was right, that when the WPATH guidelines came out 2022, the eunuch chapter caught the imagination of some of our journalists. So whilst it's still around, it's still influential, still people are quoting it against CASS, there is also a bit of an awareness that these guidelines aren't maybe like other guidelines.
Right. In the latest iteration, they removed a chapter on ethics and they included a chapter on eunuchs as a kind of gender identity. And so for a lot of people, that were already concerned, that just looked very, very odd, that we're not going to talk about ethics, but we're going to talk about eunuchs. And they linked to some sites that had sexual fantasies about eunuchs, and WPATH had been for many years clinician-led and became increasingly, I talk about this own voices movement that I think of as a publishing movement, but then, which is you can only write about the group that you're a member of, and which I think made its way into all these other aspects of life, so that only nothing about us without us, which I think was a feminist mantra about women's healthcare. And it got increasingly taken over by activists and by people with a subjective experience that they wanted it all modeled after. And I think there's this larger tension about expertise and science and adults and who's in charge, and the affirmative model became, in America, it really became child-led medicine, because it's the child knows who they are. And one of the criticisms of basing guidelines on evidence, which is a funny thing to be critical of, I think, is that whether or not these medical interventions reduce depression or anxiety, that we shouldn't talk about that, because the goal is about your body. So why criticize puberty blockers? They block puberty, right? And as you said, there is no agreement. There's no agreement on what they're for. They were supposed to be time to think. They were supposed to be a pause button, but they ended up, almost everyone who took them went on to medicate. And if anything, the CASS review is the pause button, right? That offers the, hold on, actually, we need time to think about the whole thing. And I think because America is such a litigious society, and because this is being fought through politics and the courts, I think the response here has been to litigate against it. So we can talk a little bit about this, this group of people at Yale who put out just this week, right? I think it's just this week, this response to the CASS review, which, I'll just back up for a sec to say, although it has not provided the off-ramp that many of us hoped, or that off-ramp wasn't taken advantage of, things were different here. We had, the Times actually reported on it. I had an op-ed in the Boston Globe. There were 2 op-eds in the Washington Post. I mean, it was, so the media opened up, and I can't remember, did other people jump ship at all? Jamie, was there anything?
NPR covered, we're just talking purely CASS, On Point, Meghna Chakrabarti covered CASS. But I will just segue for just a quick second.
Okay.
I would have said a year ago that I almost had a negative feeling around the US being so litigious. And I think that is kind of changing for me, because part of what that kind of litigation is showing, though, is that it is a way to bring things to light that potentially would not be uncovered otherwise. And so one of the issues that Hillary, we're on a first name basis. Sorry. Dr. Cass, struggled. I've never met the woman. I was just kidding. one of the things she struggled with was, she was asking for data. She was asking for things from the adult centers and she wasn't getting it. And what we are seeing here in the US is, in the state of Alabama, they moved forward with some litigation and they literally just said to WPATH, sorry, but we need all of your emails that were sent. We need, they can do these depositions and they can subpoena records. And what it is showing is it's showing things in a different light that we would not have seen if this was a pure, just kind of government investigation or even a medical investigation. We would have never seen all of these firsthand documents that we are starting to see in the US.
No, I agree. That ended up being a great thing. And Anna, why couldn't, how was it that the adult clinics could refuse the request to share their information? Because there's this very, very big issue with pediatric gender care, which is very few of us know what happens in the end to these kids when they become adults. And that's very much true in England, right? Because they age out of GIDS and they would go to the adult clinic and we don't know, did they detransition?
Yeah.
Are they happy? How is their physical health? I feel like someone sent around an article, but it was from a few months ago, saying that maybe it seemed like there was a higher detransition rate than thought, but we don't know if we don't have long-term follow-up, which we also have almost none in this country too. So why didn't they have to turn over their records?
I don't know if I can answer that question exactly, but I mean, there were 9,000 kids that went through GIDS and a decent proportion of them went into the adult clinics. And I think a very large percentage of adult patients are under 25. So still in some of us would still see that as adolescent or youth. And it was going to be a really big part actually of the CASS review was tracking as many of these kids as they could find all the way through their life. And in fact, the government changed the law in the UK so that would be possible, because when you transition in the UK, your NHS number changes. And so it's very hard to track people. And they asked the adult clinics to help, to write to their patients and say this is happening and to share their data. And I can't remember how many, I think there's like 7 adult clinics in the UK and 6 of them basically said no. And a variety of reasons were given into sort of confidentiality, a variety of reasons given, but essentially it's interesting the tone that's used in the CASS review, sort of, it's very British, sort of understatement, but that essentially they weren't helped to do that. And I think if you were to compare that to another area of medicine, if you were tracking oncology patients from childhood into adult services, we would all be absolutely aghast if the adult services didn't immediately come forth and say, look, here's our data. This is fantastic. We're going to be able to at last get a bit of an evidence base and find out what's happened to our patients and therefore improve care for them. So it stands out, doesn't it, as another exceptional, another exception in this area. Yeah. But I don't know I don't know whether they can say no forever, because the NHS is state owned, and one of the senior guys in the NHS has made clear his intention for there to now be a review of adult services, so that has come from it.
Yeah, I always want the data. Let's get the data.
But we should
May I chime in here? There's an audience question that sort of relates to what you just said, Anna. This is from an anonymous attendee. Can Anna kindly talk about the previous pilot clinics, now fully fledged adult clinics, who have BAGIS and WPATH connections, and advise if she knows what is happening with NHSE adult clinic review further to CASS, please?
I don't think I can answer that question. I don't.
Okay.
Sorry, I don't know.
Jamie, what were you going to say?
Well, I was just going to point out that I do think it's important for us to really be clear when we're talking about what the difference is with data versus your clinical health information. And I do want people to feel secure in knowing that a data set is so different from the release of your personal health record. We are talking about really, these are de-identified, these are sets, and these are things that hospitals use. These are metrics that hospitals use to consider care in all sorts of ways. Every single hospital you've ever been to will have a metric on how many patients developed sepsis in the last year. They can tell you a metric of how many patients were in the emergency room and brought back within a 24-hour period, how many patients were inpatient and had to be readmitted. These are basic metrics about how an institution is performing, and these are things that really should be part of the public consideration. If you are giving an intervention, how is it performing in your patient population over time?
But as you say, they're part of how an institution is performing. And what we saw from when people started looking into GIDS was that data wasn't being recorded in a systematic way. And so then maybe we've got questions about, so there might be many things that are contributing to some clinics not wanting us to look at that, because maybe that is following through into adult services to some extent. I mean, I don't know, but that's one.
I mean, in America, we don't really know how many clinics there are. I got a spreadsheet from somebody. I think it was in the 300 range for pediatric clinics. We don't really know how many people have medically transitioned, and we don't know how they're doing. And then we have our one NIH funded study, and I wonder too if the NIH can compel them to cough up more data. But in that one follow-up study, which has been touted as, proof that gender affirming care is beneficial, two of the 314 patients committed suicide, and they were
treated patients.
What's that?
They were treated patients.
Treated affirmed patients. Yeah, which is a pretty shocking rate. That's really, really high. And that was no one even paid attention to that. And so we still don't have good evidence here. And I think Bernard and I think Jamie both said that one of the responses to the CASS review, I guess in Australia and the US, is, well, we're already doing this. It says have individualized, multifaceted, interdisciplinary care, et cetera, and we're doing this. And in America, we have very little idea what's going on in any of these places. We have anecdotes and we have battles. And Bernard, what about in Australia? What's the data collection like? What's the follow-up? And is there any systematic approach to treating these kids with, well, we're going to talk in a minute about what are we treating, because it's one of my favorite questions, but tell us.
Well, as a federation, things are fragmented. So the states have responsibility for the Children's Hospital gender clinics. My impression is that the Tavistock, which was criticised for data collection, at least was publishing regular basic data on referrals, which our clinics do not do. There have been attempts to get data via requests under Freedom of Information law, but the data is very basic and patchy. Similarly, in New Zealand, the data is patchy, and it may be that per capita, for example, in Australia and New Zealand, more kids are being given puberty blockers than were at the Tavistock. One interesting aspect of CASS is that in the survey of international gender clinics, I think the Australians were the largest group. I think there were 5 clinics in there from Australia. And the University of York researchers were quite critical of a fast track system being used by 3 Australian clinics, whereby the idea seems to be to get kids who are very early in puberty on a pathway to puberty blockers if they're considered eligible. And the effect of that would be much longer, potentially much longer puberty blocking than normally happens. So, you know, we've learned a bit more about our clinics as a result of CASS, but there isn't any official coordinated collection or reporting of statistics that I'm aware of in Australia.
So some of the criticisms of CASS are that this is normal. A low quality evidence base is normal for lots of interventions. We don't have long-term follow-up for lots of things that we do. And that this is targeting this population. And how do any or all of you respond to that?
I mean, I can just jump in pretty quickly. So having read the I'm going to call it the Yale review. So the authors in this review include Jack Turbin, Joanne Olson-Kennedy, Meredith McNamara. You know, some of the bigger names that a lot of people who follow this space know. So one of the things that they wrote in here is they tried to make a comparative about using low quality evidence in making medical decisions. And they talked about neonatology, the critical care of preterm infants is what we're comparing this to. And they were talking about other pediatric critical care situations. So in the paragraph, they wrote sepsis, brain injuries, organ failures, and cancer crises. And that's saying that clinicians in these fields routinely make hundreds, if not thousands, of high stakes, evidence-informed decisions for their patients each day. That's absolutely true. In these critical care units, you know, there are a multitude of things where sometimes they are innovatively trying things while a pediatric child is actively dying, and they're trying different things to see if there's a critical decision that could be made. But these are also, it's just such a different kind of medicine. We are talking about things that are lab-based valued, imaging, the diagnostic tools. I think that the thing that I keep coming back to that's so different in the kind of medicine that they're talking to is that we do not have a clear diagnostic criteria or a way to make a determination. Who is this patient? Who is the patient going to be in the future? Who is the right patient to treat? And when they're trying to make these equivalencies, to me, they just fall flat because this is just a completely different area of medicine.
That stood out to me as well, Jamie. You know, it's a false equivalence, isn't it? Because all of those, you can have evidence of disease that you then medicate, and they're all medical diagnoses. We're talking about, you know, we were using the DSM, which is a mental health disorder manual. So they are comparing apples and pears. It's very evocative. It's a powerful argument, but actually it's not. It's a false equivalent.
Yeah, that jumped out at me. Absolutely, is we're not talking about the same thing. So when you're talking about low quality evidence, as a parent, if my child is in critical care, you know, maybe on an ECMO machine, like dying, like, sure, we can talk all we want about low quality evidence. If you can get them over
and risk taking,
what can get them over that next hurdle so that we can then reevaluate our labs and see if we're going to make it through the night. But that is not what we're talking about here. It's just,
but I think they're trying to argue that is what we're talking about, because they don't. I mean, it's interesting, that paper, what they don't address from CASS. There's a whole list of things that they don't address, but they are still arguing that even though CASS found no evidence of increased suicidality if people don't access the medical pathway, they are still essentially implying that, aren't they? That this is a life or death level of distress. That's what they're trying to imply.
Well, they call it life-saving.
Yeah.
They repeatedly say life-saving evidence-based care, which is funny because now it's going to be hard to say evidence-based. Although this paper that we're talking about, which I think Gavin is linking to for people who want to read it, I found it just made me profoundly sad. But it's saying, actually, who cares about the evidence? Because, and how can you claim that, and how can you say that, but then your argument is also that it's evidence-based, and they call this an evidence-based response to CASS, and I'm not entirely sure what evidence they're drawing on studies sometimes, but they're making arguments, and the arguments are for us to not pay attention to the CASS review. And that has been the American argument over and over again, is look away, don't pay attention to detransitioners, don't pay attention to the fact that the people showing up saying I'm trans and I need to transition, that they look very different from the population that this protocol was based on. And meanwhile, we understand that Jamie referenced the Dutch protocol earlier, and that these medical interventions for these young people, that almost all of them were same-sex attracted anyway, that there are so many things we need to look deeply at, and there are so many questions, and to have people at Yale and doctors and all of these like venerated institutions and individuals be telling us to avert our eyes, instead of we really need to get all the data. Like, don't act like the NHS adult clinic.
Can I chime in here as a
yes.
trained pediatric critical care physician
Yes.
on the panel?
Come on.
I think one, and a person who attended the last American Psychiatric Association meeting and heard Jack Turban say these words, out loud, that basically, yes, we are doing what the CASS review suggests. And the example of a patient receiving care for cancer or treatment for cancer, that whole example, trying to make that an equivalent to this issue, regardless of whether or not you believe that gender affirming care is a life threatening, like immediate, it needs immediate attention right now, we have to start these puberty blockers. Whether or not you think that, you still have to consider the risk benefit. And I can tell you, as a critical care physician, when taking care of a child who is dying, who may be on ECMO, as Jamie referenced, or maybe needs to go on ECMO, we are thinking through ahead of time what the risk and benefit is. And every single one of these cases, we may use medications off label. Absolutely. We do that a lot in pediatrics, believe it or not, because often
These drugs
we
aren't
don't
present in kids. Yeah.
we don't. Yeah, exactly.
Kids.
We don't have the data in kids, and we can reasonably, with history and our knowledge of pharmacology, apply the theoretical benefit to those children. But in every single case, we are always thinking about the risk, and that is that's the biggest difference in this particular case. And so it is a complete false equivalence. And I just don't understand how doctors, I can understand how doctors who are not medical doctors, they can try to make these kind of false equivalences, but I had to chime in as the critical care doc.
Oh yeah. And feel free to stay with us. I mean,
okay.
I want to talk a little bit about this question of what we're treating it. And in this Yale review paper, they use these phrases. Actually, let me look. That I think are so indicative of the problem. The health needs of transgender youth, or health care for transgender youth. When that's an assumption that they are trans and that there's a particular kind of care you need if you're trans, as opposed to medical or psychological interventions for gender dysphoria, which would result in someone becoming what the Dutch called a juvenile transsexual. And I also think if that was still the terminology we used, very little of this would be happening, because it evokes something very particular, a little closer to reality, right? Which is like, oh, we're intervening with the body in a particular way. So how do we navigate that? Because to me, when I read healthcare for transgender youth, I am already thinking, oh, the people writing this have already gone someplace in terms of that where I'm not, right? They're not asking, what are we treating? So, I mean, Anna, as someone who treated so many of these kids, how do you know what you're treating, and how was it at JIDS? Were you treating gender dysphoria, or were you affirming the identity of a trans youth and then figuring out which of the, in the child-led medicine, which interventions they would like?
Oh God, where to start? Okay, so first of all, trans isn't a diagnostic term. It isn't a recognized clinical term. So it's interesting that they use that. CASS doesn't use it very much, because she is trying to stay evidence-based and normal medical language. I think, and again, I'm going to draw on CASS just to think about what's going on. She talks about the concept of diagnostic overshadowing, doesn't she? And in a way, maybe this is that type of thing, in that if you look through one lens, seeking to understand things in one way, then maybe you do see 100% of these children presenting as trans. And if you believe, because there's a lot of people have essentialist beliefs, don't they, that you can be born trans, that you're trans forever, even though there is some evidence, obviously, that challenges that. So to me, it's almost like professional diagnostic overshadowing, where they're seeing things through such a tight and total lens that maybe the language we're speaking doesn't even fit with their view, if that makes sense. In terms of what we treat, go on, Jamie.
Well, just
you.
It's that it's the diagnostic process itself that I believe nobody can still clearly answer. And you can see that show up in CASS asking that, and you can see it show up in the Yale report. So the Yale review states, I think this is a direct quote, the review states, the referencing CASS, that indeed WPATH and the Endocrine Society agree that there should be a clear rationale for providing hormones at this stage rather than waiting until an individual reaches 18. Okay, so immediately I would like to ask Jack Turbin and Joanna Olson-Kennedy and Meredith McNamara, what is the rationale? Can you spell it out? Is it consistent? Is it diagnostic? Is it reproducible? Do you know exactly what condition you are treating? And if you know exactly what you're treating, what is it then that screens out on the other side? So who are the no's, and how many no's do you have? Because if it's a diagnostic situation, there have to be statistically high numbers of no's. Every person that shows up at a rheumatologist and says, I believe I have any rheumatological condition, the doctor has to say, no, you don't have it. There has to be a proportion that says, no, you don't have it. And CASS really, really gets at this. So CASS is saying that we need to be able to define clearly and reproduce exactly what condition we're screening for, and therefore what we are treating. And because nobody can do that right now, that is why I keep coming back to, this is unsafe to continue, because nobody can answer that question.
Yep, and you're very, CASS is very clear. None of the professionals she consulted were able to predict who will and who won't continue to identify as trans into adulthood, which means that in that situation, with absolutely no knowledge of who will and won't continue feeling this way, well, then you're taking a risk with every single child, aren't you? Because we just don't know.
I mean, in my own notes,
it's 5 o'clock here, so we have like about a half an hour left.
Okay.
Unfortunately. So we have about 26 questions in the Q&A. I would like to knock out a couple of these for the people who've been waiting a while. Back to the autism discussion. there are two questions that I think are pretty related. One from Lori Rudden Street. In terms of screening young people for autism, there is a belief among many of them, sorry, thanks. Thank you, Gavin. Among many of them that getting a diagnosis of autism may facilitate diagnosis of gender dysphoria. So there are peer groups and social media spaces that train the kids to know how to meet the DSM-5 criteria for autism as well as gender dysphoria. So how relevant in North America would it be to co-screen for autism in settings such as the US and Canada, where gender affirmation is still the norm? And Alice is also asking a very similar question. If CASS recommends screening for autism, what is the recommendation for kids with gender dysphoria with autism?
Well, I think in the US, if we were actually screening kids who came into gender centers who had autism like symptoms or concerns, one of the things we would be doing, and I know that some critics will say this is not the right thing to say, but we would be putting on some brakes and some slowing some things down. The other thing that I think that does is it also can really re-engage the family dynamic. So one of the issues where it comes to parents who are addressing their children who have gender distress is if we are not looking at it through a lens of an autism lens on how to deal with your young person, we might not be recognizing better ways to communicate with that person. The other thing that I thought would have been really helpful for a number of these patients was even simple things like occupational therapy. For some of them, they were having challenges with clothing or with interactions with bathing or with things that children with ASD symptoms do benefit from. These are the holistic basic treatments that we give to these kids. Why are we putting someone on testosterone when we're having these challenges if we haven't first tried 6 months or a year of occupational therapy to see if that would decrease some of the sensitivities, that would decrease some of the challenges and concerns that they're talking about, especially when they're almost so clearly interlocked and tied into what we're seeing. And the other thing I do think some of these young people are looking for, that's a whole nother conversation, is they are looking for a diagnosis of something, and they're looking for acceptance into some kind of a community and to feel like they fit in and understand why they don't fit in. And I do think that children who finally do receive the care and the diagnosis of an ASD do benefit from having some grounding in, this is, maybe why you haven't fit in. This is maybe how you can relate to your peers better, or you have a challenge relating to your peers. And the thing that I think has been really lost in this conversation is so many kids with ASDs actually do struggle the worst when adolescence onsets, that some of their quirkiness and some of their, symptoms, kind of look a little bit more like they can get through in childhood. But when your peers really start to bring this forward, you do really struggle more with that. And I really think we've done a disservice to so many of these kids not offering the baseline treatment for autism for them.
And I think some of the sisters I've talked to were autistic boys who did not like their body hair, and they were not very traditionally masculine. And so the issue of diagnostic overshadowing, it's not just that, it's the overlap, right? So they concluded that it meant they were girls. And I know with one of them, it was really seeing an autism specialist for basically help navigating the world, that helped him understand, oh, this is not a gender thing. I don't hate my body hair because I'm supposed to be a woman. I hate my body hair because I have a lot of sensory stuff. But I also think in America, and I'm curious if this is how it is in Australia and in England too, that we're all obsessed with diagnoses, and then we expect that once we figure out what's wrong, then there's just a treatment, and that's what we have. And and also it becomes a crutch. I'm just thinking about
Yeah.
a child we know who got an OCD diagnosis, and now it's for every, oh, you can't sit here because it's an odd number of people, and I need it, and everything is, everything is explained through that, as opposed to life is hard. A lot of us are weird, as Nina Paley says, sex is real, people are weird. A lot of us struggle in very basic ways to operate in the world, and then this diagnosis becomes like, okay, now I understand the key to my suffering, and rather than I'm going to learn how to handle my suffering, which is a very, very basic, as the Buddha said, life suffering, they want this intervention, and the intervention is not even right. It's fine if the intervention is OT. If the intervention is puberty blockers followed by cross-sex hormones, that is a very different thing than learning to withstand and navigate your suffering. But so, Bernard, is it like that in Australia too, with the overdiagnosis? And
I think it is, and it's partly driven in Australia by a new funding system, which creates an incentive for diagnosis of autism. The attitude of the gender clinics to autism, under the guidelines, the approach seems to be rather ideological, that a child with autism also has a right to treatment as a trans child, and it may just involve different communication methods. There's talk of using drawings with children who are not very verbal. We know, thanks to the CASS survey of clinics, that one of our children's hospital gender clinics does not screen for autism because they claim that the screening measures are not validated for the trans population.
Can I just talk to the issue of diagnosis? So I've been working with teenagers for nearly a quarter of a century. And when I first started working with young people, I'm not a big fan of diagnosis generally, but if you went near a diagnosis, often they'd recoil, like that was the last thing they wanted. Whereas in the last sort of 5-10 years, often young people will come with a list of possible diagnoses that they want me to maybe confirm. So there's been a shift in the way we relate to diagnoses, full stop. And I think across the West, and Jonathan Haidt and Lucy Fuchs at Oxford, that there's lots of people talking about that. And Cass sort of makes a really good point about, well, the systematic review that describes the demographics of these kids is, well, they're not one kid. This is an incredibly heterogeneous group with all sorts of difficulties and challenges, and not all of them will have these, but more than we'd expect with a group of kids. And so she sort of recommends, based on that, well, this diagnosis isn't capturing much info that we can use in a helpful way. So we need the diagnosis for research trials and for medical accountability. But what she's suggesting is individualized formulation. So we might not even have to call it autism, but actually just working out with a kid, well, how does this brain work? Is this a rigid thinker? Can they think symbolically, or are they more concrete? Yeah, how do they have a relationship with their body? Are they, what are they like with sensory issues? And just adding it all up, and then working out, okay, so where's the distress? Remember, as health professionals, our job is to help people stay alive and achieve their developmental milestones. So if you do that individualized formulation and you work out, well, what's getting in the way of this child functioning in the world? Well, that then helps guide your care plan, doesn't it? It's like, okay, we need to work here first, and then we go here, and then we go here. And gender will almost certainly be a part of that presentation. Maybe a small part, might be a big part, but there will also be so many other things that also need to be addressed. So I think that's a really good part of the CASS review, is this sort of move from sort of simplistic diagnostic language to looking at each individual child, their strengths and weaknesses, their context, their beliefs. And so I think that might be more helpful.
it seems so hard here. I mean, it just seems like I feel like our healthcare system, if we can call it that, is such a mess. We, of course, need the diagnoses for insurance to cover them.
Mm.
And it's, and we've, all of our, again, we just had the paper we keep referencing is by doctors, and it's like from, you know, and it came out from Yale. Like, and if that turns out to be just a completely unreliable document, a document that is essentially political and is making a bunch of arguments that are just trying to get us to not only to deal with the reality, but even to find out what the reality is.
Yeah.
That how can we trust and I saw somebody wrote this, but how can we trust our medical system? And then we don't have any medical organizations that are basically for patients. We just have these medical groups that are advocacy groups for clinicians. It just feels, I'm not to get too down on everything, especially in America, but some days I agree with Jamie that the bans and the lawsuits against them ended up uncovering information we had no access to otherwise, and it's fantastic. But how can we do better? What can we do here? I don't know if anyone can answer that question either. I guess I'd like to know if you either answer that question, or, since we're running out of time, from Jamie and Anna and Bernard, what's your ideal scenario? What would you like if you could just, wave your wand and we had these set of services, or the world was arranged in a specific way? What would that look like?
I think there's a fair bit of talk in Australia about whether or not we could save time by simply taking for granted the systematic reviews and implementing the CASS recommendations that seem relevant to Australia. But one of the points that CASS made in the webinar the other night was that there's a hearts and minds function of these reviews. So I think that a lot of people in Australia, what they're wanting is to see their politicians take the issues seriously and to have some kind of independent and effective review. We're some distance from that at the moment.
Politicians taking it seriously sounds great.
Well, some are. In fact, what has happened over the past few years is that there were very few politicians who could have a 5-minute conversation about this subject. But because parents have been knocking on doors, and because more clinicians are alerted to what's going on, there's lots of conversations happening in the background. And they are now bearing fruit at some state levels, in some parties, where there are motions calling for restrictions or motions calling for an inquiry. So I think that the number of politicians who are aware of the issues and who do take them seriously is increasing.
Yeah, I think that one of the huge arguments, that I've heard that makes it so difficult, at least in America, and Bernard, you brought up about Australia, is that the medical systems are very, very different. So that it's not easy for us to be able to capture all of the evidence. We don't know how many clinics are running. We don't know how many children are treated at these clinics. We don't know what services are offered. We don't know diagnoses. We can get some of that through Medicaid and Medicare data, but we also need to have interested parties who are interested in looking at this data as well. So I think that one of the things that I really believe that it is us, the citizens, who need to continue to push back, and definitely parents. We need to be doing more things like this, like talking about the issues, talking about the actual data, getting that information into the hands of parents, of community members. It is it is essentially what we had to deal with the COVID, pandemic, when parents started to get active and putting pressure on their, legislators and health policy, local health policy boards to recommend changes that were actually based in evidence. We need to just exercise our rights and privileges as citizens to do that, and share things like this. Share the Restored Childhood Gender Toolkit is one of them as well. Great resource there. And, just encourage people to speak up, advocate for their children, and for each other.
Anna, what would you like to see in your dream world? And tell us what's going well in the training and over there, because you've been training clinicians for the new local services, which is wonderful that they have you do that. Usually in America, whistleblowers don't usually get treated very well. So it's wonderful that they, have vindicated you and invited you to do that. So,
I mean, the thing that would firstly, I think we have to remember we're talking about so many distressed kids, and that's tragic, isn't it? We all get into all of this because it's intellectually and ethically so gritty, but actually, it's awful what's going on. All these kids asking for help. And so I guess what I would really like to see is just for things to become boring again, because we are just following. I've been trained as a scientist practitioner, so I have to always hold in mind the alternative hypothesis. Maybe the medical treatment is life-saving for many. When I see that data, I will act in line with it. I haven't seen that data yet, as far as I'm concerned. So I just think we need to move back to boring, mainstream, following our training, collecting our data, and it not be politicized, and it not have to be in the papers. That would be the dream. What's going well in the UK? We are having the discussions. It's still not easy. That there are this topic more than any, and I've worked in some quite interesting and contentious topics across my career, but I've never experienced the toxicity about this. It hooks people in really profound ways, and on many sides. So I think we are beginning to have more conversations in the UK. The NHS is taking the review seriously. Let's see how it all continues to unfold. Both our main political parties welcomed the CASS report. So I read Wikipedia on the CASS review as part of my prep to remind myself. And I looked through it, and it said, what's it, reception. And it was like the UK, like, oh yeah, they thought it was okay. They really liked it. They were happy. And then it went to the rest of the world, and it was like, they didn't accept it. They didn't accept it. They didn't accept it. So there is all smooth sailing over here either.
Well, and also, I think something that's interesting is you just had an election, and Labour overwhelmingly won, which honestly I wasn't paying any attention to, except this morning my mom said, "What do you think about the election over there?" And I said, all I know about Keir Starmer is he used to say, like, everyone should get a cervical screening or something like that, and was unable to answer the question about what a woman is, and has had some, the Labour Party has moved back to the center on this issue a little bit.
A little bit. I mean, there's always diversity in groups, aren't there? We've got a new health secretary called Wes Streeting. He welcomed the CASS report and committed to implementing the recommendations. So I'm hopeful about that. And NHS has committed a lot of money and resources to the CASS review. So I hope that they continue to follow through on the work that they began, really. And I hope that Labour will support it as the previous government did. It would be very strange if they didn't, I think.
Yeah, that would be a lot of energy to abandon it now. And I guess Jamie is working on her internet, but Bernard, since you've been covering what's going on in many places in the world, you mentioned Chile, but are there other places, whether they're paying attention to CASS or not, that are doing things that we can learn from that are handling this well?
The Netherlands is worth watching because of their recent election, and the populist right and centre-right are empowered. A motion was put up in the Dutch Parliament to have the Independent Health Council look into the Dutch protocol. And so this would involve a sort of an ethical and legal check on the Dutch gender clinics. And the outgoing health minister, I think, has just agreed that that can go ahead. I know some people in the Netherlands get frustrated when they are told that the Dutch model is the gold standard. So they've had their first detransitional lawsuits just launched recently, and the famous Amsterdam clinic certainly has its critics. In Italy, again, it seems to have a political impetus. I think it's the Forza Italia party. There was a senator who asked some questions. He was informed by parents about puberty blocker treatment at the hospital in Florence. There was an audit. Conditions, such as psychotherapy, which was supposed to be involved before the kids got puberty blockers, seemed to be not being followed. So they have set up an expert panel. There's interesting developments in South Africa too. I haven't had a chance to write about that yet, but that's quite remarkable because their health budget is under such tremendous pressure, and there is an attempt to spread hormonal treatments through regional areas. And you would think about the opportunity costs of that. One other interesting point, that this was made by Xenia of the Society for Evidence-Based Gender Medicine. And her observation is that English language facility is a sort of vector of the gender ideology and the gender medicine, so that it appears that the numbers being medicalised in, say, Italy and France are quite small, whereas in the Netherlands and Germany, for example, they're at a more advanced state of gender medicine, if you like, treating more people. So that's interesting to me, that it is in some ways an English language cultural export.
Bernard,
So
there's a
for
question
facility-
about Australia in the chat too. It says, I don't believe CASS covered the conversion therapy, the new kind. I'm assuming that Australia has it in law now, she believes. And this is from a question from Shannon. Forced to trans children by law. Can you explain that? And
yes, CASS did in fact urge caution with any legislation in the UK against so-called conversion therapy involving trans-identifying kids, because she makes the point that it's already difficult to get enough trained health professionals to be willing to work in this area. And if there's poorly drafted legislation, and it seems that down the track they might be accused of unlawful conversion therapy, then they're going to steer clear of the whole area, and then it's the kids who suffer. I mean, at last count, I think 3 of our Australian states have laws against so-called conversion therapy, in which they've expanded the old concept of gay conversion therapy into this supposed new area where there's said to be unethical attempts to change the trans or non-binary identity of kids and return them to birth sex. But I'm not sure, we may have had 4 jurisdictions. And I think that, our most draconian is in the state of Victoria, which is sort of like our Portland, Oregon, I suppose. And that Victorian legislation, I think, scared a few people in the UK who were following the debate. And anecdotally, we are already getting word that psychiatrists, for example, in some states are just avoiding gender dysphoria cases because they are afraid of being prosecuted.
Yeah.
Okay,
This is
can you clarify that? Is it the physicians who are actually are affirming a new gender identity are being prosecuted for conversion therapy, or is it the opposite?
Well, there's no prosecutions. These laws against so-called conversion therapy operate according to an international template, and they always have a specific exemption for gender transition. So, I mean, the way in which some people look at these laws is that they are really quite deceptive, and their purpose is to entrench the medicalised gender affirming model and to criminalise any alternative, including perfectly normal, ethical, exploratory side of the law. But if there's uncertainty, and we haven't had any prosecutions yet, it's not surprising if health professionals decide to stay away from this area. I mean, in Victoria, the maximum prison sentence is 10 years.
Wow, that's wild. And we don't have that prison sentence, but we have the same chilling effect of people who want to actually explore what's going on with the whole child, right, and not participate in the diagnostic overshadowing, also fear for their licenses and their livelihoods. And some of them have been reported to their licensing boards. And not to end on this sad note, but I think it's one of the most important things for us all to remember about in terms of conversion therapy is that these medical interventions that are supposedly liberating or affirming trans kids are the medical interventions once used to punish, treat, or cure homosexuality. And many of the kids in that gold standard Dutch protocol were same-sex attracted. And so again, I think just the idea of let's take these concerns seriously. I feel like that's enough, and to have this paper come out from these very powerful gender clinicians saying there's nothing to see here is not, in fact, taking the CASS review seriously. But I still have hope, even though that document depresses me. Nikki, we're going to wrap it up. Anna or Bernard, last thing you want to say before we do?
No, thanks to you all. It's been very interesting.
Yeah.
Thank you for Anna. Thank you for staying up late. And Bernard, thank you for getting up early. I really appreciate it. I wanted to have you both. So
yes, this
we
is
did
so
it.
Exciting. Long time in the making.
Thanks.
And we're excited to have had all of you. And sorry, Jamie's
she dropped
connection
off.
got lost there. Also, if we did not get into your question, there were a ton of questions. The conversation was just so great and fascinating. It was difficult to interrupt, but if you did not get your question answered, please send it to events@fairforall.org, and we will get you a response via email at a later date. Feel free to also go to our website at www.fairforall.org/donate. And that will help us to continue to be able to provide excellent webinars and informative types of events and information and publications out to you so that you can continue to be educated and just, and fight for fairness for everybody. And especially in this particular scope of a problem, this large scope of a problem that is affecting all of our youth. Thank you so much.